Okay. Patient ventilator asynchrony, how to monitor. 15 minutes. And, okay, this is a breath in pressure support mode. The two upper tracings is what you normally see in an ICU ventilator. Flow, inspiratory above the dotted line, expiratory below the dotted line. The second tracing is airway pressure. There is a small deflection here corresponding to the triggering function, and then the pressurization of the machine with a more or less square wave of pressure until a certain threshold is achieved, which is in this case 25% of the peak inspiratory flow. And the last tracing on the bottom is a transdiaphragmatic pressure that you don't use in the clinical world, but it's just to show you that in this specific case of a post-op patient, the synchrony between the patient effort, which is indicated by PDI, by transdiaphragmatic pressure, and the ventilator assistance is very, very good. There is beside the unavoidable delay to do the inspiratory and expiratory trigger, the synchrony is pretty good. However, same ventilator, so not a different machine, nothing, a different patient. This is a COPD patient, and you can clearly see that now there is a clear time lag between the onset and the end of the transdiaphragmatic pressure and onset and end of ventilator assistance, which tells us that in certain situations, synchrony is not guaranteed. And at an extreme, what happens is what we call wasted or ineffective efforts, which means that some of the inspiration taken by the respiratory muscles of the patient are not transmitted to the ventilator, which is now triggering, in this case, only one breath out of two, which means that the ventilator and the patient are out of phase, are completely asynchronous. Now, why to make a big issue of asynchrony? Well, we don't know. The first author who kind of found a relationship between asynchrony and the outcome of the patient was David Kao, working in a Winning Center in California. And he described this patient population, and at the end he concludes that patients with asynchrony took substantially longer to wean and overall had a very poor prognosis, which does not necessarily mean that synchrony generates the poor outcome. Maybe these guys have asynchronies because they are sicker. And more recently, the group by Laurent Brochard was able to confirm and to get much more in detail with respect to this relationship between synchrony and outcome. And what they found is that the patient who had significant asynchronies, as indicated by an asynchrony index exceeding 10%, at the time spent on mechanical ventilation that was significantly longer than those for whom the index was lower. And also they found that, which makes sense, because if you ventilate the patient for a longer period of time, it's more likely that you perform a tracheotomy. And in fact, there was a significant increase in the rate of tracheostomy in those patients who had more asynchronies, which again suggests a potential role in determining outcome of asynchronies, but still doesn't tell us whether first was born the egg or the chicken, something like this. Now, But the fact that things are getting more and more, authors are getting more and more interested in this, and there are few groups that produce work finalized at analyzing and detecting asynchronies during pressure support ventilation. And this is a software that was proposed by Stefano Nava and Elisa Carlucci and the group in Pavia. And there are other groups working in the same direction. The point is that these software work mostly on the expiratory phase of the breath. But as shown by Arnaud Thiel, I mean, asynchronies can occur whenever in the course of breathing. So in this case, you see, there is an effort that is at the top of the support provided by the ventilator. And at the time we made this study, we found that in some cases it was not easy to recognize asynchronies. Look at this case, for instance. Patient has huge tidal volumes. Could be synchronous, could be not synchronous. And indeed, we needed to look at the electrical activity of the diaphragm to say whether some activity was there or not. Following this finding, we decided to set up a study, and the study was finalized at evaluating how good we are in recognizing asynchronies at the bedside using ventilator waveforms. And you know, when you have a situation like this, I guess all of us would bet that there is a perfect synchrony between the patient and the ventilator. Everyone says, no, no, no. And in effect, it's perfect. I tricked you. And it is actually perfect. So, you know, there are situations like this where most of you can say, no problem, I can see in the expiratory flow and in the airway pressure a clear sign of a wasted effort. So what we did in this study, we asked 10 physicians in staff, so ICU physician trained and working in the ICU staff, and 10 residents to score a huge number of tracings. And then we performed an analysis based on a breath-by-breath basis or on a panel basis, which means in the first case we wanted to ascertain how good we were in evaluating each asynchrony. In the other one that we called report analysis, we tried to see what the real clinical impact of detecting asynchrony is. I will show you what I mean. Anyway, in this specific case, 72% of the physicians in my ICU recognize it, which concerns me a bit. 80% of the so-called expert, the physician in staff, and 63% of the residents. Okay. Now, things are a bit more difficult when it comes to something like this, because indeed the electrical activity of the diaphragm is scanty, is 2, 3, very, very low. And indeed, it's not simple to understand what happens on the flow tracings, because this is actually the mechanical transform of the electrical activity, but it could be cardiac output, it could be just the heart. And indeed, here, we were not very good. Only 21% recognized the asynchronies, about 30% of the expert and half of the residents. Also, it's not easy to recognize auto-triggering. And you know, I mean, with the upper tracing, I mean, it's really very, very difficult. And indeed, only 8%, which is 10% of expert and 5% of non-expert, were able to recognize the asynchrony in this tracing. But I did not want to cover the last one, so anyone can believe I'm in the good ones. And so be honest, no one would never imagine this type of asynchrony without measuring the EMG of the diaphragm. And you know, this kind of tracing, I mean, they are not everyday findings, but they are more common than expected. And you know what? In this case, there is a complete dissociation between the electrical activity and the mechanical activity. This is an example of full, complete neuromechanical uncoupling. So there is electrical activity not generating any air displacement, any effect of the airway pressure. So neuromechanical uncoupling. And indeed, no one recognized this asynchrony in my group. And if you want, we did this, we put all this tracing in this website. I presented this slide many times, and today I can tell you that about 90 people tried to do the test. 20 were from Mackay. Which is correct. And of 90 people who started, only 2 completed the test. I mean, this is I actually thought this was a great idea to do this, and actually the idea belongs to Art Zlatsky, but unfortunately it is probably too long, people are not motivated, or someone believes it is not anonymous, but is anonymous. And so I would like in the last few seconds ask whether someone among you as a center would be interested in replicating the same type of study, but based in many, many centers. So if someone of you thinks this is feasible and interesting, my email is in the Congress, blah, 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 and we can decide whether to use the same tracing or add new tracings. I think it's an interesting piece of information. And 12:13, I wish to thank you for your attention, and I leave room for a couple of questions.